Congrats! So you're less than 5 minutes away from being done with learning ribs. We're going to focus on inhalation dysfunctions, and we're going to do a quick review of our exhalation dysfunctions. So we know our bite mnemonic, and we know that if I find that ribs 6 through 8 are stuck down, so that means I'm feeling the bucket handles and I feel them, maybe I don't feel them go up into inhalation, but I feel them move down. So they're not moving up. Maybe it's just on the right side and I feel the other side on the left move up into inhalation and down into exhalation just fine, but the right side, the patient's right side, is not moving up. It's not getting wider like it should because it's a bucket handle or a chicken wing. So it's not getting wider as it should in inhalation. It's just going down. And so I would know that it's stuck down, which means, is it an inhalation or exhalation dysfunction? It's stuck down, so it likes to exhale. It's an exhalation dysfunction because we name it for what it likes to do. It likes to exhale. Now let's focus on the other part of it. So let's say I find that ribs 3, 4, and 5 are rising up, so that means you're doing this, right? You're kind of karate chopping them right near the sternum, not on the sternum. You want to be able to feel the ribs, so you're going to be a little bit lateral to it, but you're still in between the breast tissue. So you're going to karate chop your patient a little bit, and you're going to have them breathe in. Let's say that we feel them breathe in symmetrically on both sides, and then on the patient's right side, I feel it go down into exhalation, but the left side, I'm not feeling it go down. So they must be, if they're not going down, they must be stuck up. So if they're stuck up, ribs 3 through 5 are stuck up on the left, how are we going to name that? Inhalation or exhalation? 3, 2, 1. It's an inhalation dysfunction because it likes to inhale, it rises in inhalation, but it won't go back down in exhalation. So now let's figure out how to treat ribs 1 through 5 with an inhalation dysfunction, meaning it's stuck up and it doesn't want to go down. So let's go back to our exhalations first. So with someone who has an exhalation dysfunction, meaning the ribs were stuck down, how did we pull them back up? Because you can't just go under the rib and try to pry it back up. No, we treated them, if the rib was stuck down right here, we would go on the back side and try to pull that down, because if we pull the back of the rib down, we'll pull the front of the rib up, like a seesaw, if we remember that from the previous video. So if this is the back of the rib, and I pulled it down, that would bring the front of the rib up, which is good in an exhalation dysfunction, because if they're stuck down and we pull the back down, it's going to pull them into inhalation, which is their barrier, what they weren't doing before. But now we're focusing on inhalation dysfunction. So of course you still have your patient lie supine, meaning they're laying on their back, facing or staring at the ceiling. And so here's my example. Act like the patient is looking this way first. So if the patient's looking this way, this is their right rib. Let's say it's their first rib over here is what you're seeing. And let's say they're stuck up. So the front of the rib, if it's a bucket handle, if it's rib 1, 2, 3, 4, 5, bucket handles are going to be stuck up by getting bigger in the front, right? No. So ribs 1 through 5 are obviously pump handles. I was correct when I was saying that they are going to increase your AP diameter because they're pump handles, but I just misspoke. So sorry if I made you rethink life for a few seconds. So it's stuck up like this. So how do we push it down? You literally just do exactly what I said. You just push it down. You don't have to do anything fancy in the back. So inhalation ones are easier because if they're stuck up, you're just going to take the front part and you're going to push it down. But how do we do that in a better way? Usually you take your thumb. If you can, take the thenar eminence, so this part of your thumb, and you're going to just lay it on the rib, on top of the rib. That's the key rib or dysfunctional rib, causing the inhalation dysfunction, and you're just going to push it down. So when your patient tries to inhale, you should feel the rib try to rise. Don't let it. So the rib's going to try to rise while they inhale. You're going to resist it. They're going to inhale while you resist, and they're going to exhale, and you're going to follow it down. You're just going to help push it down. And then they're going to try to inhale again. You're going to feel the rib try to go back up, but don't let it. You're still going to hold that first barrier that you put them in. So they're going to inhale, and you're going to resist, and then they're going to exhale. You're going to push it into another barrier. And then they're going to inhale again, and you're resisting, and you're going to follow it down to the next barrier when they exhale. So it's like they inhale, and then you resist while they inhale, and then during exhalation, you put them in the first barrier. Then they breathe in while you resist, and then they exhale, and you put them into the second barrier and hold it. Then they inhale, you resist, and third barrier, you follow it down. And then we're going to do a passive stretch, or really just putting them into their final barrier. I just want to say that you usually do press with your thenar eminence and your thumb, and you push it down for a rib that's stuck in inhalation, but just be aware where your hand is positioned so you're not actually making anyone uncomfortable with their breast tissue. I should also note, because I just texted one of your scholars and they replied, because your slides do not specify to treat an inhalation dysfunction and 3 to 5 times and then put them into the passive stretch. It doesn't say that, like it doesn't specify in your inhalation slides to actually passively stretch them into that last feather edge of the barrier. But your scholar did say you are supposed to do that, because with muscle energy, you always treat at least 3 to 5 times, and then you do that passive stretch at the end. So you are supposed to do that for inhalation dysfunctions too. Anyways, so with ribs 1 through 5, which have what kind of motion? 3, 2, 1. They have the pump handle motion, because they're going to increase your anterior to posterior diameter, because they get bigger this way. So ribs 1 through 5, if they're stuck in inhalation, you have to position your patient to kind of bring them down a little bit before you start pressing on that rib. So what I mean is, if your patient is laying supine, meaning they're on their back, they're looking up at the ceiling, you're going to start flexing that head a little bit. And so if you're treating rib 1, you're not going to flex as much as you would with rib 5. You're going to have to flex it more until your finger feels motion under it, because you want to flex all the way down to that level. So you're going to be flexing over here. So you can either hold the head, or you can, if you're like me, you don't have a lot of upper body strength, so you're just going to put them on your knee. So you can have their head kind of rest on your knee or your leg to kind of hold it up while you're doing treatment. And here are your positions. So if you're targeting rib 1 as your key rib for a inhalation dysfunction, you're going to flex their head or have it lean on your knee or your leg, but you only flex them until you can feel movement under your finger of that first rib. Now, if you're targeting ribs 2 through 5, notice how they're flexed a lot more than with rib 1 treatment. So if you're going to have them lean against your knee or your knee isn't just under their head. It's a little bit further around their upper thoracic. So just make note of that. So again, you're going to flex until you feel movement under your finger. So whatever rib that your finger is lying on. So let's say I'm treating rib 3. I'm going to flex until I feel movement under my finger on rib 3. So I know I'm flexed there. Because the reason why you flex, if you put your hands on your chest, you feel those ribs, go ahead and just look down as much as you can and kind of start to round your shoulders. You should feel your ribs kind of start to go down. And that's what you want. With a rib that's stuck up, you're going to naturally want to position them to where the ribs are kind of pushed down a little bit. And then you're going to start having your patient inhale while you resist, they'll breathe out, and you're going to push down and hold it. Now ribs 6 through 10, and what kind of motion do ribs 6 through 10 have? 3, 2, 1. You should be saying bucket handle or your chicken wings, because they're going to make your patient wider when they breathe in, and then they breathe out, and they get, I guess, more narrow. There's the word. So you're not going to flex the head. Instead, because here we go. Here's your rib. So I'm going to have it on my side here. If my 7th rib is stuck up, that means instead of being down like this, it went up like a bucket handle. So we're stuck in inhalation, and I'm not feeling it go down all the way during exhalation. So it's stuck up in an inhalation dysfunction. Let's say rib 7 is my key rib. And so I'm going to try to push it down. But before I do that, I'm going to try to position the patient to where the rib is naturally down. And the way that I do that is by leaning them to that side. You can't really see because of my hair. Another thing to note with ribs 6 through 10, because you'd be positioning them, if you have an inhalation dysfunction of rib 6, you're going to want to push that rib down. But before you do that, you're going to position them where they're side bending to already kind of position that rib where it's bringing it down a little bit. And then you'll resist during inhalation and then push down with exhalation. And you'll be pushing down a little bit more out here because these are bucket handles, remember? So they rise like this and go like that. So if you're pushing out here, it's just less effective than if you're doing it right here and can actually push where its main motion is. But all of that to say, if they're side bent this way, before you reassess, put them back to neutral. That's a big part of muscle energy too. Dr. Weston did just the most amazing job of explaining this last year. So he was saying that ribs 6 through 10, if they're stuck up, you're going to position the head, which is I guess what you're going to see in a lot of books, is pick up their head, and if rib 6 on my left side is stuck up, I'm going to position them. I can hold their head and lean it towards this way until I start to feel movement at the 6th rib. But to do this, you do need to have a little upper body strength. So if you're smaller and your patient's bigger, maybe just have them position them already by leaning them towards the dysfunction. And then you're going to have them breathe in. So they breathe in, you resist so the rib can't rise, and then they breathe out and you push down. But when they breathe out, tell them, breathe out and reach for your foot, because that's going to help assist that rib going down. So they breathe in, and then they breathe out, reach for their foot. Or you can do that exact same thing with their head and be side bending it when they breathe out especially. Now let's treat 11 and 12, but before we go into inhalation dysfunctions on how to treat calipers, let's talk about where you're standing. So here's my caliper. If, let's say, I have an issue with my caliper, it doesn't matter if it's inhalation or exhalation dysfunction, there's an issue with my left caliper. So you're going to stand on the right side as the physician to treat me. So no matter what, if it's inhaled or exhaled, if I have an issue with my right sided one of my calipers, you're going to stand on the opposite side. Doesn't matter. Again, inhaled, exhaled, you stand on the opposite side of the dysfunction. And now we're going to talk about tacoing, which I should have a picture of what tacoing looks like again. But you're going to bring the patient's shoulders, the upper body and the lower body, the legs, towards you when you do an exhalation dysfunction. Because let's say my right side has a dysfunction, so you know that you're standing on the left if we're talking about the calipers. And then you are going to have me lay down on my stomach and you're going to bring my body towards you. So my legs and my shoulders towards you for an exhaled dysfunction where it's stuck down. Now in an inhalation dysfunction on my right caliper, you're still going to stand on my left side because you're standing on the opposite side, but now you're going to taco me away from you. And the way that I remember this is with an inhalation dysfunction, with an inhaled caliper, I'm going to taco into my dysfunction with inhalation if I'm stuck in inhalation. If I'm stuck in exhalation with my right caliper, I'm going to taco myself elsewhere because that's all I got, the E and the E word. So inhalation, taco inward, exhalation, taco elsewhere, or taco to the other side. I had talked with one of your scholars about your slides because they've changed since they taught me last year, because with inhalation rib dysfunctions for 11 and 12, I'm reading your slides, it says that you as the physician, you're going to exert a gentle sustained lateral encephalad traction to treat an inhaled caliper. Now, I was taught last year that you are to exert an anterior and medial force. So that's a little bit different. I talked with one of your scholars and they said that you shouldn't have any questions on the whole lateral medial thing, but if you're going to treat a caliper that's inhaled, you just need to know, push down towards the table because your patient is going to be laying down on their stomach. So you're going to push down towards the table and you're going to try to scoop that rib a little bit up towards the head. So cephalad traction. So let's say, here's my patient. I'm having them lay down on their stomach so that the rib is like this. So this is their left caliper, left caliper. So I'm standing on their right side. And then I'm gonna take my hand, I'm gonna stabilize their hip. And then with this one, you can either use your thenar eminence, which is on the thumb side, or hypothenar eminence, which is on your pinky side. You can do this, you can do this. Either way, you're going to press into the table and you're gonna kind of scoop it up towards their head. So let's say I have them inhale, I'm gonna resist it so that caliper can't go more posterior. So I'm resisting, and then they're gonna exhale. I'm gonna push down into the table and kind of scoop it up towards their head. And I'm gonna do that all in one swoop. And then they're gonna inhale again, and I'm gonna resist it so I don't lose my barrier that I put them in. And then they'll exhale, again, I'm gonna push down into the table and scoop up towards the head, and so on. And for the last one, you're gonna do that final passive stretch where you're pushing into the table and kind of up towards the head, and then you relax, put them back to neutral, so get them out of the taco position, and then you can reassess. And that's all I got. So good luck on your exam. Text me with questions that you have, and we're gonna get through this together, and you are almost 1/8 of a doctor by the time you get through the semester. Super close, it'll go quick.